Yes.
Good evening, dear friends. On the behalf of Indian Society of Critical Care Medicine, I welcome you all. This is the 7th of the series of webinar with the heading of Contain COVID. So for this session, today's moderator is Dr. Prakash Shastri. Dr. Shastri is the Vice Chairman of Critical Care Medicine at Sir Gangaram Hospital, New Delhi. I request Dr. Shastri to please take it over and introduce all the panelists and start the discussion.
Good evening, everybody. Good evening, everybody. Rajiv, welcome to the show. It's a great honor and a sheer privilege to be moderating a panel discussion and basically a discussion on COVID-associated mucormycosis with such exalted panel, absolutely the who's who in infectious disease, medical microbiology, fungal diseases, and of course, critical care specialists and ID specialists. My first person of call is Professor Arulok Chakravarti. Professor Arulok Chakravarti, besides being the head and chief of the medical microbiology department in PGI Chandigarh, happens to be the president of the International Society of Human and Animal Mycology, in which capacity he is holding an international conference in New Delhi next year. He's also the head of the WHO Collaborative Center on Fungal and Related Disease, which is based at PGI Chandigarh. As far as literally achievements are concerned, I think the less I say, the better it is, because that will not necessarily take a lot of time. So to begin with, before I introduce all the other members of the panel, and we know, Professor Arulok, that you are a busy person and very much in demand these days, I will ask the first question to you straight away. And that is, Professor Arulok, invasive mold infections are relatively rare. We have done, you have done two seminal studies on mucormycosis as well as invasive mold infections. And despite enrolling 20 big centers, which are doing a lot of work on fungal diseases, we could not collect more than 400 cases in each of these two studies. And that was over a period of 18 months. So we have to accept that these diseases are relatively rare, maybe slightly more in India, but rare all over the world. So in the presence of that context, I would exceed my brief and include all mold infections, just not the mucormycosis. I know this is mucormycosis seminar, but because you're a global person and we have had several reports of COVID-associated aspergillosis, also kappa, also from the rest of the world. How do you correlate the sudden spurt or the sudden deluge of cases, whether it is COVID-associated aspergillosis or whether it is COVID-associated mucormycosis? And we have heard just now that the government has made it as a notifiable disease, and the drugs to treat mucormycosis have become in short supply. Professor Arulok, please.
Thank you, Dr. Prakash. This is very important point I'm facing every time people are asking about it. But before going to the mucor, you also try to include the kappa issue, that is the COVID-associated pulmonary aspergillosis issue. I would rather say that we have no data very clearly about the COVID-associated pulmonary aspergillosis from our country. There is a plan to conduct a study, and this is already going on. Dr. Subhash Todi is going to lead that particular study in case of COVID-associated pulmonary aspergillosis. I would rather say that just a few lines in case of the kappa, that in case of any of the viral infection, which you have specially learned from influenza, that influenza used to damage the respiratory cilia, respiratory epithelial cilia, which is one of the big protecting site in case of any of the external agents, especially in fungal spores or anything. So in that aspect, what it had been seen that we used to see whenever the virus used to cause damage, post-influenza aspergillosis is a very important issue which have been come out. So in case of during this COVID period, first from the Wuhan itself, the cases came from China, and then it is mainly from the Europe. Patients who are treated in ICU, it had been found certain patients are going down, and few autopsies had shown that there is presence of aspergillosis. So the challenge was that why it should be having the aspergillosis in case of this COVID-associated infection, who don't have any other risk factors. They only have been, because of COVID, have been admitted in ICU. So this has been looked into, and the general conclusion of all of us who work in this area is that the COVID causes immune dysregulation. And there are two papers which Rajiv Suman also highlighted, which very clearly shows there is a change in case of the both T and B cells, which are protective in that sense. And this has really causing possibly the kappa or COVID-associated pulmonary aspergillosis. In case of Europe, the incidence in the ICU of COVID-associated pulmonary aspergillosis is quite high, even up to 30% had been shown. But somehow there is no data till now from India. So I'm not going to say that India has got very high number of cases of COVID-associated pulmonary aspergillosis. But the diagnosis of COVID-associated pulmonary aspergillosis is a big challenge because these symptoms are not specific. Even the radiological signs, when you say that is the capillary lesion, is the only feature which have been really separate out from the COVID cases, because COVID had also so many radiological features. But the thing is that which we tried to look into is that if we can collect the samples from the respiratory tract, which is again a challenge in case of COVID patient, because there is chance of contamination, and people usually try to avoid collecting sample from the deep site in case of COVID patients. Because of the lack of knowledge of the kappa in case of country, I'm not going to go into further details in case of COVID-associated pulmonary aspergillosis. But the question which is very important, that is in case of mucormycosis, I would again request in every forum I try to highlight one important thing. Please try to change this narrative of black fungi. I have been ridiculed in the international society several times. What is this black fungi? I don't know where from this term has come. Mucor is not black at all. Mucor is not at all a black fungus. It is under group of a order which is called Mucorales, which is quite not having any black color which have been seen in it. Rather, black fungus is a diatomaceous group of fungus which is distinctly having melanin on their cell wall, and that's a complete different group. So please, those people who are hearing today, start changing this narrative. Otherwise, this is India. Today, there are 4 cases of white fungus in case of Patna. What is this white fungus? If you see white fungus, that is Beauveria bassinia, which is being seen in very rarely in human infection. I don't know what they try to mean about the white fungus. I tried to look into all the aspects in this. I could not see anywhere the name what is this white fungus they tried to mean. Now coming to this issue, which you have asked me about this, why mucormycosis have come suddenly in high number. This is really a high number. I can tell me from my own center, which we used to see one of the highest number of cases of mucormycosis in the country. We used to see around 50 cases in a year. But my friends, in last 4 days or 5 days, we have got 52 cases. So 365 days and 5 days having 52 cases. And wherever I am going, especially in case of the Maharashtra group, in case of the Gujarat group, in case of the Karnataka group, in case of Tamil Nadu group, everywhere we are seeing the same story, very high incidence of cases. And this high is such high, which is unimaginable. Like Maharashtra is having around 1,500 active mucormycosis cases. Possibly India has got more than 10,000 active mucormycosis cases at present. Now the question is why? What happened in India? What is the change happened? There are 3 major factors which we could delineate. 4th factor we could not still analyze it. First 3 factors, one is diabetes in case of COVID. Specifically in case of India, because of high number of diabetes, it has been seen around 30% of the patients of COVID is having diabetes. That is a major issue. People are not taking properly the diabetic control. Second issue is the steroid use. Generally, it has been said that we should not use more than 6 milligram of DEXA per day. But I can tell you, in many centers, whenever I have collected the data, they are going up to 30 milligram DEXA. 30 means 5 times. I cannot blame them in that sense, because what is happening, the patients are going on desaturating. So they are hoping that if you go give more steroid and more steroid, the patient possibly would respond. And that is causing a havoc in this patient regarding their glucose control. It's completely changing the scenario. It's becoming almost a fertile land for the mucor to grow in that position. And yes, I think on Sunday, that was the discussion happened with the Punjab doctors. One of the doctors mentioned his 2 cases which had come today on that day. It was showing that the blood sugar level is 500 to 600. Can you believe it? So this is the scenario which we have made because of the steroid. Now, details of the pathogenesis, I am not going. There are several issues which have been now we found out, that is, which is governing to it. So I would say that first is that it is the diabetes, second is the steroid, and third important factor is, which we have studied earlier, that both in our indoor and outdoor environment, we do have large number of mucor. Our spore counts both in indoor environment and outdoor environment per cubic meter of air is much higher compared to the rest of the world. Possibly because of a beautiful tropical environment which gives this mucor to grow. So that is the major 3 issues which we could do. 4th issue, which we have not yet evaluated so well, about the immune dysregulation, how much that is governing or how much that is deciding about this mucor. But this immune dysregulation would have been in other countries. So why it is in India, I found that these are the 3 major issues which are there. Some people have said it is in case of the oxygen, or some people said it is the humidifier. Though I knew that it is not very important issue in that, but I would say that already we have studied in 3 centers, and we found that none of the center could yet isolate either from the humidifier or from humidifier water or from the pipelines of this oxygen gas. There is no mucor they could isolate. So major the other 3 issues which I have mentioned is the most important factor for this bringing out this COVID-associated mucormycosis. Sorry for a long answer to your question.
Professor Adlok, before you go away, just one more question, which is of great importance to all these practicing doctors. Now that the incidence is so high, you're talking in terms of 100,000 patients of mucormycosis all over. There's a tendency among the clinicians to prophylaxis these patients. Would you agree to that? Give antifungal prophylaxis because of the incidence being so high?
Absolutely not. The reason why I'm telling you, any cohort, wherever you plan for prophylaxis, that particular cohort should have the prevalence of the fungal disease at least 10%. You have to think about how many patients you are unnecessarily treating to save one patient. So thumb rule is that it should be more than 10%. That is there. So that's why in AML patient, in case of the induction chemotherapy, we found that fungal infection rate is more than 10%. So we have proposed that in this group, we can do prophylaxis. Till now, in case of COVID, there is not the incidence which is so high. So please don't waste the drug. Already it is scarce, and this antifungal prophylaxis should not be prescribed. We are not recommending this antifungal prophylaxis in this type of patients.
Thank you very much, sir. Any views about the combination therapy for
combination therapy? Again, I would say that we don't have any drug at present where from combination comes. Yes, there are certain situations, like suppose when you could not do surgery, there are multiple sites that have been involved, patient in a very serious condition. You know, mucor, most important surgery is one of the very important factor, because Wherever the mucor enters the blood vessel, they cause infection, they cause necrosis. And inside the necrotic tissue, where the mucor persists, the drug is becoming very difficult for the drug to enter there. So sometimes when we could not do surgery, especially say suppose a pulmonary mucormycosis, multiple lobe already affected, we cannot do a surgery, and you have tried with one drug and it is not working so well, patient is not responding so well, possibly there you can do the combination. But that would be rarest of the rare situation. Otherwise, you should not combine the drug. Already the cost of the drugs is important, scarcity is important. So there is no question of giving combination as a standard recommendation for managing mucormycosis.
For those patients who develop cerebral mucormycosis, and obviously you can't do surgery over there, would you recommend higher doses of amphotericin B?
Yes, that is there. Again, I would say that data is not so strong. It had been shown that if we use more pharmacokinetics, amphotericin B penetrates well the CNS, central nervous system or the blood-brain barrier. It can cross well, and we generally expect that it should be given much higher in dose. So that is, we can go up to 10 milligram.
Okay, thank you so much. Thank you very much. It was indeed a great pleasure to have you. I know you're very pressed for time, and I know that you would be.
Dr. Sastry, Dr. Arnold, sir has said that he will stay with us till 8:15. So I'm not going to leave him till 8:15.
Okay. Okay, but
no, I won't tell sir. 8:15 you have to be there. You have promised me. So he has to stay till that time.
I want to involve other panelists also.
Yeah, you involve other, but he has to. 8:15 I want him in between.
Okay. Okay, my next question is to Dr. Pradeep Bhattacharya. So Dr. Pradeep Bhattacharya is the Vice Chancellor of Indian College of Critical Care Medicine. And besides that, he is the head and chief of the Intensive Care Critical Care Medicine Department at Ranchi, at Rajendra Institute of Medical Sciences. And in that capacity, I'm sure that he has to deal with the governments a lot. Now, given the fact that there has been a lot of media attention given to so-called black fungus mucormycosis, and and you have heard Dr. Arnlok, Professor Arnlok's opinion and viewpoint on this particular thing. My question to you is very simple: that now that there is such a lot of pressure, I'm sure the government is putting a lot of pressure upon you. So, what kind of systems have you put in place, and what kind of advisories you have received from the government to deal with the mucormycosis cases, the deluge of these mucormycosis cases in your issue? From
yes,
Dr.
Yes. Actually, government this time I saw that government became very alert from at earlier stage, because I don't know whatever the reason is, but in our state at least the government issued all the guidelines and they said you have to make a separate ward to keep all these patients who are coming, and all the referral patients. Basically, our is the referral most apex body of Jharkhand. So here I see that all the patients from periphery are referred, and we have made a 30-bedded specifically for mucormycosis cases, a separate ward. And we have made a separate operation theater also as per the instruction of the government for all those who are COVID positive. For COVID positive patients who are having mucormycosis and they were about to go for surgery. And also there is specific theater we have defined for those who are COVID negative who are about to go for surgery. And in a similar way, in our COVID center, basically where we are keeping COVID positive patients, we had to make a separate ICU. Separate ICU.
Easier for me to hear.
Hello?
Yeah, you carry on. You carry on.
Yeah, okay, sorry. So in our COVID center, where we keep all the intensive care unit patients who require ventilatory services and high-end oxygen therapy services, there also we have made a 10-bedded intensive care unit for all those patients who are having mucor and they are COVID positive and they require high-end of respiratory support. So all these instructions have been given by the government. And secondly, as far as drugs and other things are concerned, 3 days back, government got a signature from us that yes, we need to get amphotericin B, liposomal amphotericin B, as fast as possible. So they are yesterday. Probably they got a supply of around 2,000 vials of liposomal amphotericin B for Jharkhand state, and nearly all over India they have ordered for 50,000 vials of liposomal amphotericin B. What I have heard, for various government institutes to be distributed amongst the patients who are suffering from mucormycosis.
Pradeep, can I just interrupt you? Pradeep, can I interrupt you? Just like any other government initiative, have they formed an expert committee or something of that kind at the state level?
Yes, NHM has prepared a state level expert committees from apex institutes of the states, and they have made a statement and they have passed a guideline. In our state, at least, they have passed a guideline. Accordingly, we are managing patients at different levels, whether they are coming from periphery or whether from the state hospitals or whether at the apex body. So guidelines they have issued.
Pradeep, I'll come back to you in a minute, but I want to go to Professor Mridul Daga. He's literally sitting on a hot seat. He is a director professor at the Maulana Azad Medical College, and you know the medical college, Maulana Azad Medical College, is directly under the Delhi government. So, Professor Mridul Daga, I know that you're under a lot of pressure. I don't know how do you handle it. You are the one who is approving the amphotericin B that I am prescribing to my patients. So I'm sure that you have received far many more guidelines, and how are you handling that pressure, and what kind of directives or advisories you have received from the government of National Capital Territory of Delhi?
Dr. Shastri, I fully understand and agree. I'm sitting on a hot seat, and 18th evening, and today, I think I haven't slept for more than 3-4 hours in the last 48 hours, to be very frank with you. We have been constantly bombarded with requests for this. So initially we set up a very small performer for all hospitals to give us. And we believe with whatever they were giving us and asking them to give just one report of anything available, whether it is just a KOH mount scan or a CT scan finding or a clinical confirmation or anything, biopsy or anything, a surgical endoscopy, sinus endoscopy, anything. And once they attach that with the performer, we immediately approve. The major issue we are facing is in terms of availability, because we were made available only about 2,000 vials, and we finished that within a span of 18 hours, allotting, because the demand was for at least 2 weeks for each patient, but we made a rational decision to initially give it for only 7 days to each center for each patient, so that larger number of patients can get it. But then I came to know, to my complete horror today morning, that till today morning, the distributor was not able to supply to a single person, saying about the high rains in Delhi, that the supply was coming from somewhere else. And he finally was able to supply only 527 vials to different hospitals. Then we got the message that we have a lipid emulsion, another 800 vials available. Let's see, we said we'll put that also to the different hospitals. I've sent a request to different hospitals if they are willing to take those vials also till we make arrangements for liposomal. So we're trying to make the process as simple as possible. We're just asking the hospital administration to send us an email with patient detail on that small one-page form and just one report. That's all. We're not even questioning whether the patient got admitted 10 days back and he still needs it or not. True to the judgment by the treating physician, we are allowing that and immediately asking the supplier to supply this. But unfortunately, there were some logistic issues which were to be settled by administrators, which we are doing dual things right now. And I'm hopeful by tomorrow morning, the situation should improve. That is one part. And the other part is about our own government hospitals. For there, the supply is separately being given by Director General of Health Services, Delhi government. So they are being given the separate supply. But even in private, the demand is, I think already we have a demand of around 3,000 vials already. And that 3,000 vials only when we give only for 5 to 7 days. We are not too sure about, able to continue further. It all depends on supply.
Thank you. Thank you, Professor Daga. I'll come back to you again. But I believe I have an opinion that when it comes to organizing things, and because the private sector takes care of a small number of patients and they are generally small hospitals, I will ask Pratibha Dilip to come in. Pratibha Dilip is from Ahmedabad, from the Zydus Hospital. She's head of the Department of Critical Care. Are you there, Pratibha?
I think she's not there. You can ask somebody else.
She's not there. Okay, she's not there. Okay. So I move on. I move on to Reena Shah. Welcome to this panel discussion. My question to you very specifically is that it's indeed a pleasure to be meeting you. I'm sure we would have worked in some places, some parts of England together, somewhere, some along time, maybe at different times. Otherwise, I would have known you personally, but indeed a great pleasure that you're keeping your roots with India alive and taking part in this particular panel discussion. You're an ID specialist at Nairobi. I'm aware of that. The question that I ask you is, you have got an ID consult for a suspected fungal infection in a COVID patient. Now, as a person who has not seen the patient even once before, obviously you have to go there, you become familiar with the patient, organize yourself, organize your thoughts, and then maybe suggest a possible course of action in which you try to your best that you are not missing out anything. And I'm sure that when you're seeing fungal infection, your condition is not as bad as in India, where every fungal infection is more likely mucor unless it is proven otherwise. So my question is, what is your approach to a patient who is suspected fungal infection post-COVID or during COVID?
Thank you, Dr. Prakash, for that question. And indeed, I've had multiple consults for such ever since COVID came about. So I think the first thing we have to do is go back to basics, get a good history and physical examination. Now, the commonest thing we've seen here is candidemia, especially in the critical care, and it's usually Candida albicans. Of course, in India, it's Mucor now. And so you've got to go with the epidemiology of where you're working. So of course, if you're in Kenya and England, your fungal infection is not going to be Mucor number 1. It's going to be Candida albicans. But if you're in India, currently, you've got to think of mucormycosis. And with this webinar, that is what I'm going to focus on. So basically, a good history, have they had COVID? Are they recovered COVID? How much steroids have they been on? Have they been on high-dose steroids? Have they received tocilizumab, which increases your risk of fungal infection? So good history from the patient. Are they diabetic, and have they had high ferritins? So those are the things in the background. When you go to, have they got fever? When you go to examine the patient, you want to see, is there nasal blockage, congestion, discharge? Have they got any facial pain, numbness, swelling, headache, orbital pain, toothache, or blurred vision, paresthesia? And then if you're thinking of pulmonary mucormycosis, which is another thing you've got to have a high alert for, again, similar symptoms, but with hemoptysis and worsening respiratory symptoms. You could have had a lung CT when the patient came in, and if it wasn't very typical of COVID, you need to go revisit that to see is there anything else that would make you think of a fungal infection. And usually these patients have in the past have had repeated negative galactomannan and beta-glucan tests, and I know you're going to discuss that later. And whenever you see a patient and you're thinking of mucormycosis, you've got to think of it as a medical emergency. In medical school, we were taught of medical emergencies like MI, septic shock, etc. When you have a patient with mucormycosis, every medical person should think of this as a medical emergency. And these patients must undergo appropriate radio imaging, MRI of the brain, if you think it's central mucor, or a CT scan for the thorax, and rhino-orbital cerebral imaging. If as an ID physician, I thought that this patient was having lesions in the mouth, in the nose, I must call in the ENT surgeon. Biopsy, histology, radiological confirmation is very, very important. You've got to do that so that you confirm the diagnosis, because the treatment is not a simple treatment. Amphotericin has a lot of complications and side effects. So you've got to really think of that. The other thing you can recommend is reduce it on high-dose steroids, reduce the steroids. discuss with the primary physician about the immunomodulating drugs to reduce that. So that's a sort of overall, but I just wanted to say that it is a histological diagnosis. If you can get culture, that's also very good. So it's putting everything in together. I personally have treated mucormycosis in our cancer patients, and often you may not get microbiology, but putting the clinical and the radiological feature as we wait for more specialized tests from microbiology saves the patient. So those are my thoughts, and that's how I would approach a patient with a fungal infection. Of course, if you think of other fungal infections, for example, a candidemia, which is what we commonly see, the simple things to do is to change the lines. We know central venous catheters are big risk factors for having candidemia, for Candida hemoluni, albicans, so you change the lines, urinary catheter, but of course that's not true for mucormycosis.
Thank you. That was very kind of you to elaborate upon the entire approach to these patients, because at the end of the day, the basics are the basics and they will remain basics. And obviously, if you stick to the basics, you will probably arrive at the diagnosis. Nice to hear your British accent. You maintained that. Good. I have now. I hope that Professor Anlok is still there, because it's not 8:15. Are you there, Professor Anlok? No. Okay, so I come to Rajiv Soman. Rajiv Soman is a very good friend of mine. He has moved from Hinduja Hospital in Mumbai. Rajiv Soman, you are there?
Yeah, I am here.
You're there.
Hi, everyone.
Pratibha, I can see Pratibha now. Okay, but anyway, I'm sticking to Rajiv Soman. Rajiv Soman has moved from Hinduja Hospital in Mumbai to Jupiter Hospital in Pune, and he continues to do excellent and human service in Pune. I have my own connections in Pune, so I can say that, vouch for it personally. Rajiv Soman, Reena Shah did mention about the way you would manage these patients. I would confine you to mucormycosis. And obviously, when we talk about mucormycosis, the usual presentation that we are getting nowadays is rhinoorbital and possibly cerebral mucormycosis. How would you approach this patient and how do you manage them?
Yeah. So everything begins with suspicion, and then we should pursue the diagnosis. And as has been said before, the only way to make a diagnosis is to have a biopsy. There are no biomarkers in this condition, and therefore, once the suitable symptoms, radiological findings are there, by and large, almost everything is, at least to begin with, in the ENT area, and therefore the ENT surgeon's service is very, very valuable. So a sinoscopy, a nasal endoscopy, and any suspicious area should be biopsied. And you can get a diagnosis within maybe an hour or so when you do the calcofluor stain after dissolving tissue. So that's a very, very good way to make a quick diagnosis. Of course, to make a diagnosis, a fully confident diagnosis of an invasive, we possibly need a biopsy.
Can I interrupt you, Rajiv?
Sure.
Now, you have taken a sample, a biopsy sample from the nose by endoscopy. Would you, in addition to sending it for biopsy or histopathological examination, would you like to send it for culture as well?
Yeah, of course. See, the first thing which we should be done immediately is this calcofluor staining, because that result is there within a very, very short time. The next part is culture, obviously. And the third part, which should be sent in formalin, is the histopathology. So the histopathology also tells us whether there is tissue invasion, whether there is vascular invasion, whether the mold is eliciting an inflammatory response, and so on. So very, very rarely, mucor can also be a colonizer. Okay, but when you take a sample from a disease, it is very unlikely that whatever you are seeing is just going to be a colonizer. Okay, so for all practical purposes, when you take it from a sample which is showing disease, it is a true infection. But to really show that it is invading tissue is very, very important. So for that, you need the biopsy. Biopsy will take a long time, and therefore we need not wait for all this. We can definitely act on the calcofluor stain. And I would even say that you can sometimes start a dose or two of the medicines if the suspicion is very, very strong. Like today, when you're going to see 30-40 patients in the hospital, it's very easy to spot what is probably mucor. It's very important to make a distinction between a bacterial infection and also between aspergillus and mucor in a timely fashion. Okay, because we might be wasting valuable time giving antibiotics, perhaps jacking up steroids, which is going to add fuel to the fire, and perhaps using voriconazole, which might be very, very detrimental if you are actually dealing with mucormycosis. It increases the pathogenicity, vascular invasiveness, and so on of mucorales. And therefore, this distinction is extremely important. So all this can be done within few hours. Then you should also stage the disease. Remember that once you see it in one place, it may be an important thing to check the CNS as well as the lungs, especially to see whether other sites of infection are there. What is the feasibility of doing surgery? The physician must never think that he has started treatment unless adequate surgical debridement has been done. And then finally look at the reversible causes which you can treat and consider what you can use as adjuvant therapy, which might there be about 4 or 5 things such as hyperbaric oxygen, maybe deferricesox, caspofungin selected, aspirin, statins. Now these might be considered as adjuvant therapy, but we know that all this has uncertain efficacy, cost, some side effects, as well as availability on site. Now, unless you have HBO, that is hyperbaric oxygen, in your own hospital, it's probably not worth sending the patient somewhere else and messing up his fluids and sugars and all these things during the journey. So if it is available on site, yes, certainly one should consider that. So the pillars of treatment: debridement, antifungal therapy, adjuvant therapy, reversal of the underlying cause, and possibly a good multidisciplinary approach. So I would think of these 4 or 5 aspects.
2 small questions, Rajiv, don't go away. The role of amphotericin B deoxycholate and the role of itraconazole, now that there is such a shortage of antifungal drugs. And I know you will take it with a pinch of salt. But for the audience,
my views known already on the email, Prakash. You might have read those, but basically, amphotericin B has been grandfathered into the treatment of all invasive fungal infections right in 1959, almost 60 years ago. So there was no control group at that time, and so there has been never any control trial to show the efficacy. In fact, that is the grandfather drug, and every new drug which comes along is pitched against amphotericin B to see whether that is going to work. Then came its modifications. Okay, so the molecule was packaged in the form, first the lipid ones and then the liposomal one. So the drug is now packaged in liposomes, which are very tiny, and they release the drug only in close proximity to the fungus. So actually the apparent volume of distribution becomes very less, but it is selectively targeting the fungus. It is also taken up after some time by the cells of the RE system. So you have very high levels in the liver and spleen, to some extent in the lung, comparatively low levels in the brain, and very low levels in the kidney. So that's how it is distributed, and most of the time that works very well. Additionally, there are more factors such as it has immunomodulating properties because of the liposomes. So that is also an advantage, and you can actually, because it's diverted away from the kidney, it is far less nephrotoxic, and therefore you can actually jack up the dose to, as everyone knows, 5 to even 7 and 10 milligram per kilogram. In other words, you can actually realize the full potential of this very valuable drug only when it is packaged in the form of liposomes. I think I'll stop.
the deoxycholate form.
Yeah, so everything else that I said, opposite of that is deoxycholate. So deoxycholate has much more diffusion reactions. It has overall less therapeutic efficacy. Your ceiling dose for mucormycosis is just about 1 to 1.5 milligram per kilo. So all these are the problems, and therefore when you are pushed against the wall, you have no liposomal amphotericin B available at all, then maybe you can use deoxycholate. There was a time when that was the only preparation, and all of us have grown with using deoxycholate, and we did have good results. But after liposomal amphotericin B came up, definitely we did not have to interrupt treatment and resort to renal replacement therapy and all these things which were sometimes required when we were using deoxycholate.
And what about itraconazole?
Itraconazole has shown some efficacy against some of the mucorales. I have my own issues with the drug because Basically we have to understand that molds do not have clinical breakpoints. Okay, so you can measure their MICs, then you can have epidemiological cutoffs, which will tell you whether this organism does have or does not have a mutation. So only on that basis, there are no clinical outcome studies which will tell you that this is a clinical breakpoint. So there aren't clinical breakpoints. So there are some Mucor alleles which will have higher epidemiological cutoffs than the typical MICs, and there are some, I don't want to name them on this forum. So in those situations, itraconazole may not work. The other issue is the tablet versus the liquid preparation. The liquid preparation, which contains the cyclodextrin, is far better, has far better bioavailability. The tablets have very erratic bioavailability. We struggle, of course, to achieve a level, and the therapeutic level is at least 1. So to get that with the tablet is not very easy. Here you have a disease which is acute. Somebody said that it's a medical emergency. In that situation, how is itraconazole going to work? It doesn't even work in histoplasmosis. When you have bad histoplasmosis, the treatment is induction with amphotericin, and then you come down with itraconazole. And here we are dealing with a disease which might be perhaps more aggressive than histoplasmosis. And if we are going to think of using this drug, I think it is going to be a very great difficulty. So with all this pharmacodynamic, pharmacokinetic considerations, I don't think it has a good place. Now, at the end of it, if you have no antifungal drug to give at all to the patient, maybe something is better than nothing. But I would not, I would then say that, okay, then try and do a maximum surgery, reverse the underlying cause, maybe use deferricirox, maybe use hyperbaric oxygen, everything else that you can possibly do. And then maybe a little help from itraconazole.
Thank you, Rajiv. It was indeed a pleasure to hear your arguments in favor and against, almost like a lawyer in Supreme Court. And I am sure that a lot of clarity of thought has come into all the people who have listened to whatever you have said, and especially your command over the pharmacokinetics and pharmacodynamics. That is simply hats off to you. Thank you very much for being in the panel, but don't go away. There could be other questions for me to ask you. I'll move on to, I can see Pratibha Dilip now. Is she there?
Yeah. Good evening.
Good evening. Sorry we missed you.
Dr. Shastri, sorry to interrupt you.
Yes,
Can
please.
I request all the panelists to please take the question answer in the question answer box and the chat box? So there are many question answers there. If all the panelists can take 1 or 2 each, then it will be easy. Thank you very much.
I'm asking those questions in between. I'm seeing them. I'm asking those questions. So my question to Pratibha Dilip was in continuation to the questions that I asked to Pradeep Bhattacharya and Professor Mridul Daga. Both of them happen to belong to the government sector, and they have obviously under a lot of pressure from the government, and they have been getting directives and advisories and so on and so forth. And even the drug has been under government control in Delhi at least. So my question to you was very simple. You are working in a fairly well-organized private setup, and it's not a huge setup. And I'm sure that you are in the thick of the things when it comes to handling this kind of cases. As such, you are handling COVID, so obviously you're handling the corollary to the COVID, which is the mucormycosis. My question to you is, what kind of systems have been put in place in your hospital to deal with this kind of emergency?
So we've made a loose COVID care team, which comprises of intensivist, ENT specialist, radiologist, and a microbiologist. So every patient where we do suspect mucor or loosely, all these people, they take a look at this patient, and we come to a conclusion as early as possible, and then go for further treatment.
Is any particular guidelines that you have received from the government?
No, not yet. Not yet.
Not yet.
Only
So
today we came to know that it has to be notified now.
That is only today. That is only since today onwards.
Yes. Otherwise, in fact, right now the major problem is shortage of amphotericin. So the government, the hospital said unless the patient can procure for 10 days of amphotericin, we are not really admitting these patients for last 3 days, because there is a major shortage of amphotericin.
Huge. It's a cruel blow to the patients, I must say.
Absolutely. It was very difficult to tell the patient that you have to procure for your medicine. I mean, many of them come with the hope that hospital will provide, yes, but then what to do?
Yeah, so these are really torrid times, and I'm sure that all of us are feeling the pressure. I'm losing my temper at times because of the sense of helplessness that we face. We faced that in COVID because of the shortage of oxygen, and now we are facing the same thing with the mucormycosis because of the manpower shortage. Because there are only so many ENT surgeons, there are only so many ophthalmic surgeons who are ready to work round the clock, 24/7. So, I mean, it's sometimes, despite the fact that all of us are aware of the treatment protocols and everything, but we are not able to deliver it to the patient because of the sheer numbers. So it
Yesterday, we couldn't get even posaconazole. That was a sad part of it.
Yeah, I'm sure. So we move on to another close friend of mine, N. Ramakrishnan. He's chief of critical care and sleep medicine at Apollo Chennai, and has been a good friend from a very, very long time. Has served in a stint in the executive of the Indian Society of Critical Care Medicine, and does a lot of work in educational field, including the education of nurses, teaching on nutrition, and so on and so forth. I've had some occasions to work with him in these kind of endeavors, and I can't imagine the kind of hard work that he puts in. Dr. Ramakrishna, my question to you is, how many cases of pulmonary mucormycosis have you seen in the recent search, and anything different from what all has been spoken about the treatment of mucormycosis that you face in the management of pulmonary mucormycosis? Don't go away, there's another part of this question which I'll ask you later, but pulmonary mucormycosis, just confined to pulmonary mucormycosis, how could you approach them and how do you go about managing them? I'm sure you must have seen quite a few. Ram, are you not there?
Yeah, I'm very much here.
Okay.
I think I'm the odd man from the south. So our situation is a little different compared to what I'm hearing from all of you. Yes, we are seeing mucormycosis, no question. But the numbers that we have is probably much lesser than what you all are seeing, for whatever be the reason. In fact, initially, some of the patients that we were finding who were having mucormycosis were all from out of state for whatever reason. Those who got transferred from our neighboring states seem to be the ones that had it. But we are now encountering more and more, and a lot of them are being picked up even on an outpatient basis by our ENT surgeon and ophthalmic surgeon, and then subsequently after surgery being brought into the ICU. As we speak today, we probably have in the main hospital about 2 to 3 mucormycosis patients. Most of them seem to be the rhinocerebral kind of mucormycosis that we are seeing. We have rarely encountered pulmonary mucormycosis. Just one patient that I can recall in the last few weeks who was admitted to one of our facilities and actually had a pulmonary mucormycosis. So the answer to your question is yes, we are seeing. The numbers seem to be less, but the shortage of medications is probably a national shortage because of the raw material issue. So yes, we do have problems with getting either liposomal amphotericin B or the regular amphotericin B. All of those have been an issue. We do have protocols in place on what to be used and what step-down therapy can be used. So we are, although not ideal, our step-down therapy includes posaconazole and, if necessary, isotretinoin. Either one of them don't seem to have enough data, so I would openly admit that. But because of the lack of availability of amphotericin B for the prolonged duration of treatment, we have been talking about those as alternative step-down therapy.
That really, brings a question to my mind, and that's a hypothetical question. One of the reasons for increased fungal infection, especially Candida in the intensive care unit, is because we use broad-spectrum antibiotics and we use them for a long period of time. Would you say that maybe in the rest of the part of the country, we are probably throwing antibiotics at our patients, and maybe that's why we are getting this selected out mucormycosis or fungal infections in general?
I am really glad you brought that out. I can talk about our hospital systems for sure. And I think the entire administrative aspect of managing these COVID infections and preventing the secondary infection starts pretty much from pre-hospitalization. So Apollo Hospitals Group, and particularly from Chennai, we have been driving a lot of protocols even to our community physicians who are treating COVID, sending out the message of avoiding early steroids. Early steroids is harmful. In fact, we have started a critical care outreach services where the Indian Medical Association doctors from Tamil Nadu can call us anytime between 8 a.m. to 8 p.m. and discuss any patients with us. And it's a free service that we have offered to the IMA physicians and the smaller nursing homes. So we're really trying to cut down unnecessary use of steroids, unnecessary use of antibiotics right from the early stages. I mean, so many of even the mild cases seem to be getting at least like an azithromycin and a doxycycline being started routinely as an outpatient. And we are driving the message across to the entire community saying it is absolutely not necessary. In Chennai, we are really lucky to have several ID physicians in our panel, or very reputed ID physicians whom the entire country knows. We're really lucky to have them. So our antibiotic stewardship program is very robust, and really a lot of the medications are restricted. We don't use unnecessarily. We have our own protocol on what dose of steroids to use so that we don't use higher dose of steroids unnecessarily. Any of those is automatically discussed by a panel. We have very strict use of tocilizumab or any of those medications. So I really think that it has helped to have these kind of protocols in place, having a very robust stewardship program. And not to forget, the hospital has also developed a program called Recover. So the post-COVID patients who go home are being followed up by a multidisciplinary team, including pulmonary, internal medicine, ID physicians, whoever else, even psychological support, all of those. So we have a Recover clinic, which also helps us to pick any of these complications early. If they come with symptoms, we're trying to identify them early so that we can treat them.
One last question. Just like I asked Pratibha, have you received any advisory from the government on any particular way of managing these people, a guideline or a protocol?
I mean, several of us are actually in the government's advisory panel. So we haven't specifically received any directives from the government on management of mucormycosis, but the Tamil Nadu government by itself has come up with protocols for the peri-hospital management, which is frankly, not to, brag about ourselves. I would say it's one of the very good protocols that I've actually seen for management of COVID.
Thank you. Don't go, we might be asking your questions later on also. Om Shivasta, I'm glad that you're there. One of the rare occasions that I'm seeing you, and it's been ages that I saw you last. And it's indeed a great pleasure to be seeing your face at least and talking to you online. The question that I wanted to ask you was because I'm dealing with a patient who is post-liver transplant and has developed now extensive mucormycosis, not only involving the nose and the eyes, but also the brain. And if I really look hard, possibly he might be having a disseminated mucormycosis. Now, our experience with COVID in PLHA patients was not too bad. I mean, we could manage to treat quite a few of them, and they were discharged, of course, to a lot of reach out care that my hospital does. My question to you is that now if your patient with HIV comes to you with the mucormycosis, number one, how would be your approach different from what all we have discussed so far? If not, then you can just say that do the same thing. And the most important thing that I want you to highlight upon, which probably we as critical care physicians don't do really well, is something that how would you prognosticate the severity or this seriousness of the condition to the relations of the patient? So 2 questions.
Okay, so thank you, Dr. Shastri. Both are very important questions, and thank you for having me on this panel. The first question is relevant to a liver transplant patient. I understand that you.
No, it was. I mean, I saw a liver transplant patient, but I know that you deal with a lot of HIV patients. So the question is in HIV patients.
Okay, all right. So, well, one of the most important things is to actually evaluate what is the extent of the immunosuppression in such a patient, what kind of treatment he's been taking, what is the viral load, because as we all know, viral loads which are uncontrolled in HIV are always going to be a matter of great mischief in whatever treatment that you're giving along with the treatment for HIV. So important for all such patients to have a controlled viral load under control for as long as possible to as low as possible. these patients are also going to be having a skewed response from their immune system point of view, especially with their CD4 counts, their T cell population, their helper cells particularly. And so it is your first job as a treating physician would be to evaluate what is the extent of immunosuppression and what is the immune system looking like. So we look at a number of things, that is CD4 counts, CD8 counts, you look at CD4, CD8 ratios, you look at CD4 percentages, because all of that matters. All of that matters in terms of prognosticating what kind of opportunistic infections and complications your patient is going to be looking at. Once you have established that part, then the treatment remains pretty much the same, except for your needing to keep a much closer vigil and a much closer eye on making sure that people will respond to the treatment that you're starting. So we've already discussed with previous panelists before me, the role of amphotericin B may or may not be as much as it is touted to be, but there are other agents like posaconazole or isavuconazole that will come into the maintenance part. If your patient of Mucor is immunocompromised for whatever reason, here we are talking about HIV, but if you've got active disease, which is going to require chemotherapy, malignancies, immunosuppression, for whatever reason, then such patients are going to require a longer duration of therapy. Average duration of therapy is between 3 and 6 weeks time, but that can be much longer in patients who are immunocompromised. The mainstay of treatment, however, is debridement of dead tissue and making wide excisions. Surgical debridement still remains the mainstay of good recovery. It is not medical management, it is surgical debridement. So it will be a combination, but the lion's share of the treatment for such patients is going to be in surgical debridements. You will probably need to make a multidisciplinary approach in assessing not just the immune part, and I'm talking again because we're discussing HIV here, but also the ENT, the ophthalmology, the reconstructive part. All of that will need to come together, and there will need to be a prolonged follow-up in all such patients. Dr. Shastri.
About the relations, the prognostication to the relations of the patient.
So again, I think it would depend, it would probably be on the same lines as you would prognosticate any other very sick patient. If you've got a condition like this in somebody who's immunocompromised, you would probably need to make an assessment as to how soon your patient's immune system is likely to recover with whatever treatment you're giving. So if you were to start a certain antiretroviral therapy at any point, it's going to take at least 2 weeks time before your patient starts to make any kind of immune recovery. You will need to discuss all of this with the patient. You'll need to probably explain in great detail and multiple number of times as to how sick this patient is, what are the chances of recovering from one condition and its complications and not going into another set of complications. These also require huge amount of counseling to patients and their families. It's something that we have seen that the physician or the surgeon or the physician and surgeon and the rest of the hospital team needs to sit together with the family and speak to them in great detail and tell them as to how sick the patient is, what are the chances of even a partial recovery over a prolonged period of time, and that if the outcome is good after that, then that is terrific, but you still need to make it absolutely threadbare and speak as honestly and as freely as possible to everybody concerned.
And that is at a premium, because the time required to do all these kind of things it's really a huge demand upon your other commitments. And that is where perhaps wherever we try to cut it short or maybe make it a bit brief because we think that we have said it all, somehow or other they still come back. ठीक तो हो जाएगा ना? So that is a usual question that we come in. But I think your answer that you have to be absolutely honest towards the relations of the patient. And I think they appreciate the honesty. They all realize that it's a serious disease and on a background of a serious disease. So obviously they are at least mentally prepared, because To tell you the later part of the story, the wife of the patient who was a liver transplant patient, she actually came to me today morning, and she said that if you tell me that the outcome is very poor, I would rather like to, go for terminal weaning or something of that kind. I would rather like him to go in peace. That was the words which normally we have to sort of, get it out from the patients rather than the other way around, which happened with me in today's case. And that is why I included this question on counseling with the patient's relations, because they are the ones. The wife is the one who is going to be affected. The rest of the world will move on, but the wife's world is going to change forever. So thank you very much for your elaborate answer on this and your empathy towards your patient's relations. I really appreciate whatever you have said, and I'm sure that a lot of younger generation of doctors who are listening to this discussion would also take it home and take it to their heart, that this is as much their responsibility as is the prescription of drugs and treatment of patients, putting central lines, intubating patients, and so on and so forth. This is equally important in the management of the patient. So that brings me to Dr. Rajiv Suman again, depending on so many questions that I've asked. Professor Arunlok Chakravarti in the beginning has already answered this question, but now that he's gone and people have joined later on, I would ask you as to why that COVID is all over the world, but COVID-associated mucormycosis has come as a tsunami in India. So why Indian patients are so particularly vulnerable to mucormycosis?
India has always had the dubious distinction of being the diabetic and mucormycosis capital of the world. Okay, Western countries are talking about Kappa, and to my mind, aspergillus is far less common in the setting of post-COVID as compared to mucormycosis. Chiefly, I think the problem is in the air, and there are lots of spores. The climatic conditions and everything else seems to be giving us this dubious distinction. And therefore, when you have a patient who also gets diabetes, hyperglycemia, diabetic ketoacidosis, all these other factors, we know that that expresses certain receptors on the endothelium as well as the epithelium. And then we know that mucorales have certain ligands called as cottage 3, which is absolutely distinct for mucorales. No other living forms have this particular ligand. So when you have this, you certainly have a recipe for disaster. Frankly speaking, I am not surprised that this is happening. The way we are misusing steroids, the way we are vulnerable to all these things with these high spore counts and so on, this was something which was waiting to happen. It's an unfortunate reality, but not unexpected. Now, there are differences in the incidence of this disease in the first wave, in the second wave, as well as in the regionally, there are differences. Most patients, actually my observation is like this, that when we have seen our own patients who were treated and followed them longitudinally, my impression is the incidence of mucormycosis in such patients is only about 1 to 1.5%. Okay, so we are deluded, so to say, with a huge number of cases, but they are all having a referral bias. So they do come to places where there are ID physicians, where there are good intensive care facilities and so on. But we don't truly know what is the denominator. So when they come from other towns and other smaller places, we do not have a denominator as to how many of such COVID patients were there and were treated similarly. And out of them, how many did develop mucormycosis? So I suspect that if things are like Dr. Ramakrishnan said, that if you have systems in place, if you're actually following guidelines, trying to avoid misuse of all these drugs, including steroids, the chance of the incidence is not so much. It's definitely very less. I'll speak to Ram Gopal Krishnan and somebody else to really see what is their impression of incidence. And I suspect that it will be low. What does Om think about it?
Before Om answers that question, Rajiv, one more question, Rajiv, which is very stupid question. And that is there something called a maximal dose of amphotericin B that you can give to the patient? I want you to answer it.
Of course.
And before that, I have to ask you to tell that there is absolutely no role of any echinocandin in the management of mucormycosis.
Okay, in a general way, what you are saying is true. But if people would like to know, I'll sort of make the whole thing more complicated, because there is a small role. But remember that that is only in conjunction with pollenes, that means with amphotericin B. So it is believed that there are some sites, means glucan is also being synthesized by Mucor, and by giving a pollene, you are opening up certain sites inside. And therefore, now the echinocandin can also work to some extent. Remember, its status is of an adjuvant therapy. It is not primary therapy. It can only work in the presence of adequate neutrophils, as well as in the presence of adequate amphotericin B. And it's also been shown only for rhizopus, and that too also for only rhino-orbital cerebrum. Okay, so there are lots of caveats. So my very simple answer is yes, there is no space for using any of the echinocandins. But if you look very, very deep into it, there is a small place for using it.
And the maximal dose of
amphotericin B maximum dose is 10. I mean, we are talking, if you are talking of deoxycholate, then it is 1 to maximum 1.5 milligram per kilogram per day. If it comes to liposomal amphotericin B, it is said that you can give up to 10 milligram per kilogram. But I generally don't want to give more than 7 or 7.5 milligram per kilogram. It's very interesting to also know that the dosaging, there is a ceiling weight which you should consider. If you find somebody who's weighing in excess of 100 kilos, the body weight which you should be using for making that calculation is 100. There is a ceiling there. And in fact, even for people who are a little bit below 100 or something like that, maybe 80, 90 kilos, it's probably wise to use the lean body weight and not the actual body weight for computation. The reason is this, that this is not distributed into fat, and it has a saturable elimination kinetics. Basically we don't know how it is eliminated, but partly it is eliminated in feces. And that remains constant almost regardless of the body weight. And therefore, these are the dosing instructions in normal body weights as well as in obesity. If you're asking another question, like what is the total amount of amphotericin B which you can ever give to a person, then that was only an old idea that you have to give this many grams or kilograms or whatever else of amphotericin B. The endpoint is actually clinical. It is not dictated by the total weight of amphotericin B which you have utilized for that patient, also not on the duration. It depends on the clinical, radiological, and microbiological stability as well as improvement. The minimum treatment will have to be obviously for 6 weeks, but beyond that, it could range for 3 months, sometimes even 6 months or longer. And like Om had also said, that if somebody is going to receive chemotherapy or otherwise going to remain immunocompromised, much longer duration treatment is going to be required. And therefore, you will have to de-escalate at some point or the other, or transition. I don't want to use the word de-escalate. It is a transition from a pollene-based or amphotericin-based treatment to an oral treatment, presumably less expensive, easier to take, and so on. So that would be one of the new ASOPs.
Really, thank you very much. This is kind of fables or something which has been passed on by our professors on to our students, and it is carrying on. And I'm really glad that you have put the things in proper perspective as to the cumulative dose of amphotericin B is concerned. You had asked a question to Om Srivastav. Om, would you please answer what Dr. Soman had asked you?
Rajiv, do you mind repeating, please?
That's a tough one.
I've forgotten.
I don't seem to remember, but you could add your comments to all this.
Okay, well, I think it was something along the lines of whether there is a role for having a system in place where you could identify or pick up or make sure that people who have got early Mucor may not be lost into the crevices and may be treated appropriately in the early part of the disease. Yes, I think definitely there is a role. I think while there is a role, I think by the time we get such a system in place in India, the epidemic may have plateaued or stopped peaking, and that the numbers will be far less urgent. I don't think we can put something like that in place, and I'll tell you why. And you can call me a skeptic, but with the guidelines that have come out for COVID, with the kind of indications for steroids that are percolated down to, the B towns and C towns and the village levels, I don't think you're going to be able to put a stop to this. The amount of steroids that we are seeing right now is so rampant. And if COVID continues for a few more months, we are going to see even more steroids being used and abused. I'm sure all of us on the panel have seen up to 40 milligrams of dexamethasone and 1 gram daily for 10 days of methylprednisolone. So with that kind of steroid use, of course, you're going to be inviting fungal infections. And that mucor is only one of them. There'll be other fungal infections, other bacterial viral infections that will all be present. So I think there was probably a role for making a plan for such a system in place before the mucor epidemic started. But now it's a matter of picking it up as soon as possible, getting them to a hospital, involving the surgical part first, starting the debridement, and only then going on to medical therapy. That would be my impression about where mucor is right now. I think systems are very important, and I think that like Dr. Ram mentioned, Chennai is far more organized, and the Chennai model, I don't know if there's anybody here who can speak to ICMR or to New Delhi. The Chennai model should be replicated all over the country, but I'm not sure if there is enough time at this time. Right now, we are going to be firefighting for a long period of time.
Thank you. I just wanted to mention one thing. When you said, I'm sure all of us have seen 40 milligrams of Dexa, I can very proudly say we have not seen it. We don't see that kind of steroid use here. I've not seen a 1 gram Solumental given. Yes, I have seen 250 milligrams given sometimes, but that's probably the highest I have seen. So I really, really think that having protocols in place has helped us.
Yeah, but Ram, what we are talking about is not really what is being done in our own institutions. These are the kind of prescriptions which people come from outside with.
Yeah. But even when we get patients from outside, we have not seen it.
Dr. Prakash, can I just have a quick comment? What the others are? Sorry to interrupt you. I should not have been jumping in. In fact, the unfortunate part about steroid is that people have started giving steroid without understanding when it has to be given and when not has to be given, and how much has to be given. If that simple thing they have just followed, probably we would not have seen what we are seeing. So there can be other factor, but definitely it is steroid which is contributing a lot, whatever. Unfortunately, people are desperate, and everybody is desperate to treat the things early. Everybody think that by starting steroid on 2nd day, 3rd day, just COVID positive, they will be able to cure the disease. Problem started when people started treating the radiology. They started treating CT scan, they started treating MRI, that CT score is 5, start steroid. At that too also, they start with 40 milligram BD with no symptom. 40 milligram methylprednisolone BD is the minimum thing which GP and physician are starting. And that's where the problem is starting. So by the time patient is coming to you, sick on 10th, 11th day in storm, he has already received 80 milligram or more of methylprednisolone equivalent, or maybe Dextrona 2 cc 8 hourly is the common people. They don't understand 8 milligram the OD dose. They are thinking Dextrona means 2 cc 8 hourly or 236 hourly, which is being used for anything. So everybody is following what they feel like following, rather than following a standard protocol. And that's where all problems started. Sorry for this quick comment, but that's what I thought to convey. I mean, Ram, you can just add to this what I
just wanted to add one thing, and that is, it is continuing for weeks.
Not weeks. It is a months. Forget about weeks. People are taking 6 weeks of steroid in this dose without any reason. Oxygen is off, but they are on steroid. No end up giving steroid. Nobody wants to stop steroid.
Dr. Ram, I'll come back to you. You must have heard Rajiv Suman saying that in our personal patients who we have followed them longitudinally, and I believe that he meant that these patients were treated in an organized manner with all these caveats into place. Would you agree that just because you have the system in place, that is why you are not seeing such a high number of mucormycosis? So that means the basic thing lies when it comes to prevention of mucormycosis in COVID patient is proper management of COVID itself.
I would really like to think so. And I think all the panelists have mentioned that. And I think, like having stringent protocols, ensuring that steroids are used appropriately and only in appropriate doses and only for the appropriate time, and not doing unnecessary scans, not doing, extended doses of whatever medications we are using. All those do make a difference. I think it's back to the basics. If we can get more and more people to comply, and I completely agree with others saying this may happen in our facility, may not happen in all the facilities around us, but the more people around you that you can make sure that you comply. And that's why I was mentioning to you about our program, that people can call in and if they have a doubt, and we try to, half the time we are telling them not to do something, tell them please stop, please don't give this, please don't. I mean, it's more like don't do rather than do. So I think that really has helped. It's been hard on us. I mean, really, like our consultants are carrying these phones in turns and trying to answer the call. It has been difficult, but I think it has really helped the overall healthcare system deal with this question.
Let me ask Reena Shah. Reena Shah, how much of maximal dose of steroids have you given, and how much amphotericin B maximal have you given in your lifetime so far in a particular patient?
So, in a particular, so for COVID, dexamethasone 6 milligrams, we stick to that. So the way we manage our patients, low saturations, we give them dexamethasone 6 milligrams. If the CRP starts going up, or we think they're going into cytokine storm, we give them tocilizumab. The ones that don't get better with tocilizumab, we may pulse them with steroids, but that's after a multidisciplinary approach. None of our patients are put on regular antibiotics. It's just such a no-no. In terms of amphotericin B, we see a lot of cryptococcal meningitis where I'm from. So we do use a lot of amphotericin B. At any one time, we would have about 3 to 4 patients on that drug, and really no more than 3 to 5 milligrams per kilo. And on a titrating dose, because we've seen so much renal dysfunction and patients requiring dialysis. So we're very careful for that. So, some of the doses that are spoken about here, of course, if they're necessary, but unless they're necessary, we shouldn't be giving them. Having said that, the reason I am part of this group is when I called Rajesh Mishra to say, why is everybody in India with COVID being put on dexamethasone? These are asymptomatic, at-home patients, family of mine, who were told by their doctors to be put on dexamethasone. And I had to really battle it to make them not be put on dexamethasone. So I think there's a lot of widespread abuse of dexamethasone, which is probably one of the contributing factors of high rates of Mucor in India, along with probably all the other things people have talked about. We have a lot of diabetes. 80% of our patients with COVID have diabetes. The ones who've had low saturations, we've put them on steroids. We've not, our weather is probably pretty similar to India, but we've not seen as much Mucor as has been described in India. I mean, I'm hoping we're not going to see it in the next wave, but I think there's a lot of abuse of drugs outside at outpatient level. So before they reach critical care, before they reach the inpatient, so at primary health care, and patients are also just going out there and buying dexamethasone. I spoke to a colleague of my husband's who's in Bombay, and he said, oh, he's fine, he's at home. Oh, the doctors put him on high-dose steroids, he's going to get better. So that's the impression that's out there. I'm really glad that this group is giving out the message not to do that with all the podcasts and the seminars, but there has to be a lot more done, because patients believe, and I'm of Indian origin, so I know the way Indian origin patients think that the more drugs you take, the better you get. I think it's a real change in mindset that's going to be required to reduce, and we're seeing the complication of that. So a lot of antibiotic abuse, a lot of steroid abuse, and we're seeing that. Maybe that's why the West hasn't seen as much. What we're seeing is the sicker patients coming into critical care, being put on carbapenems, and we're getting the other candidates. So fungus is just there. It's just waiting to develop and erupt in patients when the condition is right? We know simple augmentin can cause vulvovaginal candidiasis, and that's happened to a lot of people. So if a simple augmentin can do that, imagine the strong drugs and the high-dose steroids. It's just a really fantastic petri dish the patient becomes for the fungus to grow.
Welcome, Arindam Kar. I can see you over there. So I'll take the privilege of being the moderator and ask you questions, and you are bound to answer it because you're my student. Given the kind of mayhem that we are facing every day, day in and day out, and we are under a lot of pressure, would you try to suggest to me that is it because of the pressure that we are working under, or because of the workload that we are working under, we are indulging in this kind of, let us say, unethical practices, and that is why we are paying the price for it? I mean, I know it's a very hypothetical question, but I would like, because you think out of the box, I would like you to answer that question.
Thank you, sir. The idea is, sir, it is no doubt that the immunomodulators are answer to a lot of questions. But whether the people who are trying to put this answer to those difficult questions are qualified to know what they're doing. So I think we have done everything in there, but in our capacity. But I think both government and the private stakeholders have not put in very big effort to educate people, particularly the practitioners who are treating people. In fact, in a 1.35 billion population country, it won't be able to, for us, the critical care people or pulmonologists or trained internal medicine people, to reach out to every patient. So whether we should be more proactive in training and creating awareness among people. Sir, I am receiving prescriptions of patients where almost the doxycycline, ivermectin, and steroid is ubiquitous. Almost everyone is getting right at this moment, but now maybe a little bit of black fungus terror would be. But I have a very apt question to the panelists, as we got an opportunity to hear. So whether we have a quantifiable risk factor, whether just steroids, or it is the duration and dose or cumulative dose of steroids along with some MABs, they are more important, because some people who really justifiably need steroids are now panicked to get it. They are thinking that whether it would lead to a mucormycosis, and people are unable to decide which is a more bigger menace, whether the COVID itself or a subsequent mucor that may find. So I think that question and also need to be addressed. That the incidence is not that much, the incidence that we are having of the COVID itself.
Dr. Rajiv Sobhan, are you there? Can I ask you a question? Or is it gone? Arindam, to answer that question as to the quantifiable risk factors, the FISF has actually done a study, and other than diabetes, unfortunately, they could not find a risk factor. They could not sort of put a finger on the dosage or the duration of steroid therapy in the limited number of patients. There are around 250 patients that they did in the study. I was part of that study, so that's why. But I don't have the access to the whole data as yet. But I thought Rajiv Subban would be having it, so he finally did the manuscript. So I thought he would be knowing it. That paper has not been published as yet, so it's why the details of it are not completely known. But we could not find the diabetes was the only risk factor that was associated with mucormycosis, COVID-associated mucormycosis. But unfortunately, they could not prove the association of steroid use or the cumulative steroid dosage that was given to the patient with the onset of mucormycosis. So I think so far our knowledge on that aspect is a bit limited, and I'm sure a lot of work is going on, and FISF is deeply involved in this process. And maybe in the months and months to come, in the few months to come, we would be having some of the answers, if not all the answers. So thank you for your input on this thing. I need to ask Deepak Govil, how long do we continue? How much time do we have?
Sir, the time is, you can have 10 minutes, 10, 15 minutes. I know you can moderate this session for long hours, but
no, no, we have covered most of the topics, and by and large we are wearing down the same thing, that the higher incidence of mucormycosis that we are seeing in India at present, or the pandemic of mucormycosis we are seeing, is probably because of inept handling of the COVID patients itself. And this time the number of COVID patients, especially in northern India, was absolutely humongous. I could never imagine India having 4,000 deaths per day, and that to continuing over days and weeks together. This was something unthinkable when we were dealing with these cases in the first wave. So that's why perhaps the pressure upon us has become a bit too much. Probably because of the pressure, there have been some occasions in which we have been irrational in our management of these patients, and perhaps somewhere along the way, some of the things probably have snapped. Oxygen problem, for example, that really, at least 2 consultants in my unit, they actually cried because of the oxygen failure of the oxygen pressure. So maybe there are a lot many factors involved, which probably cause the breakage of the infection control that is normally practiced in most of the hospital, and that could have perhaps led to the increase in the mucormycosis cases. Of course, that is not to take away the fact that the irrational use of steroids, and maybe because the guideline came that the dexamethasone actually reduces the stay and improves mortality. That study really led to the usage of steroids in a big way. And that perhaps gave a license to a lot of people who gave steroids to left, right, and center with impunity at home, and so on and so forth. So I believe if Rajesh has got anything to say, or Deepak has got anything to say, from my side, I think I'm calling it a day when it comes to asking questions to my panelists. Rajesh Mishra, your last word. Yes, Dr. Daga, please.
Yeah. So coming to the same question which Dr. Rina was saying and all that, we are also seeing during non-COVID times cases of mucormycosis, like what Dr. Dr. Chakravarti was saying, that 50 cases in a year. We are also seeing similar number of cases during our routine period, And this sudden spurt, I think, is definitely because of an additional factor of steroid misuse. There is no doubt overuse and prolonged use and for weeks and all that. And now what we are getting is calls from patients for last 10 days or so. They're having some headache, and they are becoming very, very, very,
Paranoid.
Yes. Some of them have got their CT scan done. Some of them have consulted an ENT. And so they are so panicked. So their bottom line is that, yes, what Rama was saying and all that the information which percolated down, and even the discovery trial, the dexamethasone 6 milligram, it in fact became a platform for misuse of steroids rather than being utilized properly. And of course, the antibiotics, another issue which we need to discuss subsequently. Everyone is put on a prophylactic antibiotic in most of the setups, which is very, very unfortunate for the COVID. So these things we need to really be very, very cautious and very upfront about.
Thank you, Professor Daga. You have almost done my work of sort of making a conclusion out of all the discussions that we have had. Rajesh Mishra, can I ask you to put in your final words? Are you there? If you're not there, then I'll request Dr. Deepak Govil. On a personal note, it was indeed a sheer privilege, and I must thank the Indian Society of Critical Care Medicine for having organized this particular webinar. And I hope that this webinar has a much wider audience than what we have had today. And probably, I'm sure Deepak would record this and put it on the website for all and sundry to see it for a longer period of time. And as personally concerned, with such a galaxy of stalwarts being present, it was a huge privilege to have acted as a moderator and asked you questions. So thank you very much, each one of you. I don't need to name all of you, but each one of you, thank you very much for having participated in this webinar. And you have really made things crystal clear as far as the management of COVID is concerned. And if you manage COVID well, obviously mucor may not arise at all. And if it does, then we have a protocol in place to manage this kind of patients. I hand over to Deepak Goyal to take it forward. Deepak.
Thank you very much, Dr. Shastri. On the behalf of Indian Society of Critical Care Medicine, I thank you all, especially all the distinguished panelists. And I request our General Secretary, Dr. Arindam Kar, to say a vote of thanks and close this session. Thank you.
Thank you, everyone, particularly my teacher, Dr. Prakash Shastri sir, to moderate this entire session, and all the respected senior panelists to give their valuable time amidst their entire busy schedule and all three. And also Dr. Govil and Dr. Rajesh Mishra to come up with this idea. We know that there are a lot of suggestions coming, and we are working hard to come up with a executive summary, which would be pretty soon. And to inform you, the next 3-4 sessions would be also very interesting and all relevant on the current issues, particularly on oxygen stewardship, ECMO, and lung transplant, like that. So I think with the permission of the President, sir, I will close the session. But maybe we will come up with one more update may be required for the Mucor. I think it's not ended there, because we might have some more ideas, and some new medicines are also coming. So we will also come up with that also, like deoxyglucose. The RegenCov is being launched in India, which is a combination of monoclonal antibodies. So stay tuned, stay with us. We will be coming up with a lot of more informative things. And all these sessions will be available in our website and also in the YouTube. So people who have missed the live session, they can go back and look into it, listen to it. Thank you everyone for being with us. Thank you.